Hi, we're back with COVID Sense. The goal of this series is to help you understand the evidence so you can make informed decisions regarding COVID. This is the fourth segment of a four-part series on vaccines. We have Deanna McLeod, principal at Kaleidoscope Strategic, here to walk us through some more data.
Well, we want to figure out if our plan is grounded in good medicine. We want to know if we're leveraging our limited resources in order to achieve herd immunity most quickly. And we also want to see whether this plan is going to protect us from variants. So those are some of the questions we're going to ask of the data today. So let's dig in and learn about herd immunity. All right, in order to be able to evaluate our vaccination plan, we need to get our heads around this concept of herd immunity. Here we have a schematic of a population, and in a population, you have all sorts of different individuals. You have healthy individuals with robust immune systems who are able to mount a response to an infection and recover with very little symptoms and really very few consequences. We have people who are healthy who are at high risk of exposure and exposing others. They circulate fairly broadly in a population. We have our infected individuals, and we also have vulnerable people. Now, vulnerable people in this context are defined as people, for whatever reason, who are at risk of severe disease because they would not be able to mount a robust and balanced immune response against the infection. So what is herd immunity? Herd immunity is basically where we try and ensure that the majority of the population is immune to a given disease, in this case COVID-19, so that it is unable to spread between the population. So generally speaking, if you're immune, we're going to assume that you cannot spread the disease, or you'll mount an immune response which will minimize spread. And ultimately, in our plan, we want to make sure that vulnerable people are not coming in contact with infected people. We want everybody to be immune. We also want them to be surrounded by people who are immune, and so that the infection can't pass on to vulnerable people. And ultimately speaking, in order to limit the transmission of the disease and ultimately to protect our vulnerable populations, it's estimated that we would need to achieve between 60 and 80% of people becoming immune to do that, to reach herd immunity. Now, traditionally, this has occurred through natural immunity, which is when people are naturally exposed to COVID-19 and recover. And it's also developed, it's been enhanced recently through vaccination. So vaccination can kind of help us along in that process of developing herd immunity. So now that we understand herd immunity, let's talk about COVID-19. So COVID-19 arrived on the world stage with a bang in 2019. I remember in January reading headlines about some strange virus spreading through China and thought, oh my goodness, that's a world away. How could it ever touch my door? And before I knew it, March 2020, we were in lockdown. Because the virus was new, basically, we had to assume that everybody was non-immune and susceptible to infection. That's the blue dots that appeared on everybody's chests. We also knew that the virus could cause severe disease in some. Again, those are our red individuals. And that it even could spread, or that people who were infected could not show any signs. So it could spread seemingly asymptomatically. So in order to protect the vulnerable, social isolation measures were put in place. So people who were suspected to have COVID-19 were instructed to stay at home and quarantine for 14 days. The same thing if you were traveling. And special measures were put in place in our long-term care facilities. And our elderly were asked to take special precautions in order not to come in contact with anybody that could potentially spread the disease. As a society, basically, we've been in lockdown for almost a year, where we're taking measures not to infect anybody else by coming in contact with them. We're working at home. Our kids have been schooled virtually. People are missing out in connecting with loved ones at various occasions, all with the goal of limiting spread. So now in March 2021, we have many more tools in our toolbox, and we know much more about COVID-19, which places us in a great position to make better choices about how to limit spread. All right, let's dig into our Ontario vaccination plan. So first and foremost, the cornerstone of good medicine is informed decision-making. It's where you clearly convey to those receiving a treatment what the risks and benefits are. So let's take a look at a couple things. First of all, the Ontario COVID-19 website says that vaccines are safe and effective and the best way to protect you and those around you from serious illnesses like COVID-19. We know that vaccination clinics are popping up all around and that we're trying to vaccinate as many people as possible, which is great. And this type of procedure, which is used for other vaccines, is appropriate whenever they have limited toxicity, and that the toxicity is limited to local reactions. However, the mRNA vaccines are a different animal altogether. You can see here, which is a clip from the Moderna Baden New England Journal of Medicine paper, that which lists the percentage of participants who get adverse events, which are reactions, mostly COVID-like reactions from the vaccine. And according to placebo, or here the first and second dose of the vaccine, we can see that in the patients in the placebo arm who actually got COVID-19, there were very few severe reactions in the healthy adult population that was studied. However, when it comes to the vaccine, you can see after first dose it wasn't very high, but after the second dose, you had about 15% of people who experienced grade 3 adverse events. That means that the adverse events, the COVID-like toxicity, or the toxicity of the vaccine was such that it prevented them from carrying out their daily activities. And here we know that 55% of the people who receive the vaccine are basically going to have the toxicity of the vaccine interfere with their daily activities. And you can see this starting to show up. Unfortunately, because a lot of these clinics have very little follow-up and clinical oversight, we're only learning from it from the headlines. So here we have a headline that talks about how 2 Blue Jays players have been basically put on the injured list and pulled from their games because of the side effects from the COVID-19 vaccine. So one of the first things that we can say about our plan is that we could do better in informed decision-making, that the true safety of the vaccine needs to be more clearly conveyed to those who are being vaccinated so that they can make good decisions. And also, we need better clinical oversight. I'm glad that the Blue Jays team has great clinical oversight. They've got people on their staff that can look into that. But what about the people who are being vaccinated and sent off from the clinics? Do they have sufficient clinical oversight should they encounter severe side effects caused by the COVID-19 vaccine? Moving right along to the elderly, we are prioritizing vaccination of the elderly and the vulnerable. I would say that these are the 2 populations that have been most affected by this pandemic. Both the severe severe COVID cases and the hospitalizations, ICU admittance, and even deaths have been really mostly in people who are either elderly, mostly, and if younger, people with comorbidities. So we definitely want to protect these populations. However, it really should be emphasized that their randomized safety and efficacy data, which is the one where we can actually tell if something works or not, was very sparse in even healthy elderly people who were included in the trial. There were very few of those. There were also a few at-risk people, but we weren't sure if they were at risk due to exposure or severe disease in many of those trials. So it's unclear how people who have comorbidities and underlying chronic inflammation conditions will respond to the vaccine. We do know that the spike protein, which is what the mRNA vaccines are training our bodies to produce, have pro-inflammatory qualities, and so we don't really know how that will affect inflammation in the body. In terms of the elderly specifically, we do know that they are frail and immunescent at times, which means that immunescent means that their bodies aren't able to mount a balanced and strong immune response, which means that even if we give them the antibodies, they may not be able to fight COVID-19, and we may not be able to avert severe disease. So we do need to be thinking that not counting on efficacy in that population. Moreover, we do know that 15% of people who receive the COVID-19 vaccines will get, those are healthy Blue Jay type players, will get severe side effects to the point where it will incapacitate them. So we do not know what that will do to our frail elderly population. We do know that in the CDC has recorded a number of deaths due to vaccination, and those have been mostly in frail, they've been mostly in people in long-term care facilities. So it is very possible that these frail individuals are being harmed by the vaccine. However, because we're using this off study, we won't actually know who is being injured and who isn't. So let's just wrap it up. I think some of the concerns with prioritizing the vaccination of populations who haven't been well studied is that it might place them at risk of severe toxicity. There's a biological argument for that. It might give people, facilities and families a false sense of security, thinking that their loved ones are immunized when they're not, and that might lead to greater exposure and severe disease as a result. And also it does not let us achieve herd immunity because mostly elderly people specifically in long-term care facilities don't circulate widely, so they don't contribute to herd immunity. So it's questionable whether we're helping them specifically, and it is also questionable whether we'll be helping society achieve herd immunity. So bottom line here is that we need to be more discriminate in our use of vaccines in off-study populations. So let's talk about our safety surveillance system. Here in Canada, we've been reassured that as the vaccine is being rolled out, that safety is being carefully monitored. So we took a look at the Canadian Health Info database that monitors and describes safety data coming in from the vaccines. So you can go to that site and you'd see a graph that's similar to this. These are the adverse events that have been reported up to now, I guess as of March 26th. So one of the things to think about are that there are two types of surveillance system. There's an active surveillance system where you're actively soliciting side effects from people who've received a treatment. And they tend to reflect fairly accurately the events that are actually occurring. Then you have passive surveillance where you give somebody a treatment and you send them home. And later on, if something occurs, they're like, I wonder what happened. And I wonder if this was associated with the vaccine. And I wonder where I should go to report this. So there's a whole bunch of barriers to reporting in passive surveillance where what tends to happen is you get an underreporting of the actual events that are occurring just because it's difficult to make an effort to go report them. There's no system in place often, and you may even not make the connection between the event and the treatment, for instance, in this case, the vaccine. So I would say that passive surveillance is appropriate for really well-studied drugs with established safety records, and I wouldn't say that the mRNA vaccine is such a treatment, and it would be questionable whether it would be adequate for something that's been approved in emergency use and that's being used in off-study populations. For instance, how we're using these mRNA vaccines in people who aren't necessarily healthy adults, for instance, our frail elderly. So we took a look at the Canadian Safety Database and we began to analyze it. We did some comparisons with it and the CDC passive surveillance database. And one of the things that we found was here in Canada that the safety effects, even for known AEs or the safety signals for known AEs, are dramatically underreported, which is very concerning. Here in Canada, we had to multiply events by thousands, whereas in CDC, it's only by tens. And so for me, I would say that it's questionable whether the safety signal coming from this database would be adequate to identify the rare adverse effects that you would expect to see as any treatment rolls out in a broader population. Additionally, the safety data is monitored by event. And to be able to interpret it well, it would be best that it would be, I suppose, reported by patient, by dose, and by specific adverse event. So presently, it's really hard to figure out, how many, the incidents per person, etc. So I would say here, things to think about is that our safety net has a very weak signal and may not be sensitive enough to pick up adverse events in the broader population so that we can protect people who are receiving the vaccine. And secondly, I would say that active monitoring would be more appropriate as we're using it in less studied populations than passive monitoring. So a couple things to think about, maybe something to advocate for with your local MP. So let's go on to the decision of Ontario to administer single doses. When I say single doses, it means to delay the second dose by 4 months due to a vaccination shortage. Now, there's a lot of confusion around how well that's going to work, a single dose. And there's a report by the HEROES study. It was a real-world study conducted by the CDC on first responders and their response to the vaccine and the safety of the vaccine. And in that study, they reported that the effectiveness was between 80 and 90% for a single dose. However, one of the things that we need to remember when we're looking at something like this is that this study was a prospective cohort study. So a prospective cohort study is down here on our evidence-based pyramid. And generally speaking, it's limited to hypothesis generating. So what you would do is you'd say, oh, this real-world study said this. That's really interesting. We should check it in a randomized controlled trial. However, we've already done the randomized controlled trials, and the randomized controlled trials, which are up here, which should be practice changing, meaning we should set our standards of practice to that, say that only 2 doses were really studied, and that the benefits of a are much lower. So here we've got our antibody studies that were done, and we can see here that 1 dose does not produce a lot of antibodies. 2 doses, even a week later, that you get the second injection, which is here, and then all of a sudden antibodies begin to be produced. And after a few weeks later, 2 to 3 weeks later, you get full antibody titers. So one of the things that we do know for sure is that 1 dose does not produce enough antibodies in the lab. And secondly, when we actually look at how it's used in randomized controlled trials, this is the biotech trial, we know that you get a 95% relative reduction in the risk of confirmed COVID-19 cases with 2 doses. However, when you factor in the efficacy for 1 dose, which is half of the population received 1 dose, the actual efficacy is 52%. So when in doubt, when presented with effectiveness data and efficacy data, we always go with the efficacy data. And what this means is that only 1 in 2 people who are vaccinated are actually going to be immune. So 52% of a population means that 1 in 2 individuals are actually immune. So you can get your vaccination, think that you're immune because it says 50%, but really you may or may not be immune, and we won't actually know if you're immune or not. So we need better transparent communication regarding the efficacy of a single dose. My concern is that we have people going out there thinking that they're protected when they're not, which again might lead to greater exposure and transmission of the virus because they feel that they are immune when they're not. And again, administering 1 dose does not provide us with a great way forward in terms of achieving herd immunity because we aren't sure who is immune and who isn't immune, and we're only getting immune by about a half step rather than a full step forward. All right, let's chat variants of concern. So here in our picture, we have the original COVID-19 strain here. And then we have 3 strains that have emerged on the world stage that are concerning: the B117, the P1, and the B1351. They're concerning because they're mutations to the spike protein that allow them to allow for facilitated entry into our cells, which means that they spread more quickly. The UK strain spreads more quickly by a factor of 42 to 82%, this one by 50%, this one by 150%. Additionally, they're of concern because the variants might be able to evade vaccine-induced immunity because the immunity for the vaccine is specifically based on the spike protein. So when they did a test called neutralizing activity, where they put the strain in a petri dish along with antibodies that were produced through vaccination, what they find is that the ability of those antibodies to neutralize the virus was decreased by twofold for the UK strain, by less than 6.7-fold for the Brazil strain, and less than 8.6-fold, and about 8.6-fold for the South African strain. So we are seeing less neutralizing activity with the vaccines relative to these particular variants. However, we do need to remember that that's not the full picture, that the ability to mount a balanced immune response based on a healthy immune system and also a healthy innate immune system also affects your ability to fight off variants. So at this point, it's unclear whether they cause more severe disease, but it is clear that because they have increased transmissibility, it is likely that our vulnerable populations will be more exposed, and therefore we're likely to see increases in things like hospitalization, ICU admittance, and death, simply because the variants are able to access our vulnerable populations. So a couple thoughts. One, we need to have increased mindfulness in protecting our vulnerable populations. We also need to have an urgent need for more information on the severity profile of the variants. And we're looking into that presently, and hopefully we'll have an episode that actually discusses the data related to variants sometime soon. So let's talk about how all these factors will come together in our goal to achieve herd immunity. So first of all, we've prioritized vaccination of vulnerable people. So as discussed in previous slides, many of these are elderly people who are immunescent, and we're not completely sure whether even with antibodies they'd be able to mount an immune response against COVID-19. Again, they haven't been very well studied, so it's unclear how effective the vaccine will be in that population. We've prioritized the vaccination of those who are who take care of them. So giving priority to people in long-term care facilities and people who care for vulnerable individuals, which is on study. It's something that's been well studied. However, because we're giving them one dose, we're sending people out. That means that 1 in 2 people who've been vaccinated actually won't be immune to COVID-19 based on the randomized controlled data. What this is doing is, in addition to having the vulnerable people here where we're having direct exposure, what we're doing is we are creating opportunities for indirect exposure of vulnerable people, for instance, here, and here, at a time when we really need to be ensuring the protection and the lack of exposure of our vulnerable people because of variants. So I would say that we really need an abundance of caution regarding exposure of vulnerable individuals. And just because you've received 1 dose of a vaccine does not mean that you are immune. I think, unfortunately, we're going to have to err on the side of caution and protect our vulnerable population. So let's discuss the types of immunity. Here on the left-hand side, we have vaccine-induced immunity. It's specific to the spike protein, which is produced through the mRNA vaccine. We develop antibodies to the spike protein. These are stored in our immune library for later use. With natural immunity, we're exposed to all the proteins of the COVID-19 virus and are able to produce a host of different antibodies. These, again, are stored into our immune library for later use. We now know that these spike antibodies last at least 6 months, and that the natural COVID-19 antibodies last at least 9 months. So one thing to think about is that these are long-lasting antibodies, which is unlike initial reports, which is encouraging. The other thing to remember is that our ability to mount and a response to a future infection is not dependent on the number of antibodies that we have circulating. We have to remember that this imprint has been stored in our T cell and B cell memory, and that other antibodies can be produced should a vaccination or an exposure occur at a future date. So one of the things that we do need to recount is that although we are able to produce antibodies to a spike protein, and we have short-term data showing that this is able to potentially reduce COVID-19 infections, one of the things we know about, we don't know how it's going to work in the broader population because it was studied in healthy individuals. However, with natural immunity, we know that this has been, that many individuals of many different types have been exposed to COVID-19, and that those who've been able to recover from COVID-19 have had very few reinfections, meaning that it is an effective way of developing antibodies and fighting future infection. However, we're looking forward to data on vaccines and how efficacious they'll be in future dates, although we're already starting to see initial reports of vaccine breakthroughs, meaning that people who were vaccinated being reinfected with COVID-19. What do we need? We need more research on the protective effects of natural immunity, especially at a time when variants are circulating and where we have a vaccine shortage. Let's take a look at how many people may actually be immune here in Ontario. So these are the statistics for Canada. We note that if you look at total cases, you subtract active cases and those that are recovered, that we have a 98% recovery rate here in Canada, in that people who've been infected to COVID-19 are alive and have natural immunity to the virus. What that means in terms of Ontario is that about 25% or 3.75 million Ontarians actually have natural immunity. That's natural, broad, and long-lasting immunity that could very well be very effective against future variants because it's not dependent solely on the spike protein. One of the things that we may want to consider when we're doing our vaccination plan is to ensure that these people are considered and that priority vaccination is given to those who have not been exposed and who have not recovered, i.e. developed natural immunity. So how do we navigate our current climate? It's a difficult situation. We have a shortage of vaccines. We have variants on our doorstep that are highly transmissible. We have a hospitalization system that's nearing capacity, at least here in the GTA. So the government of Ontario has enacted stay-at-home orders, in addition to the quarantine orders that we have for people with infected individuals, and also the extra precautions that we take with vulnerable populations. I think that this needs to be enhanced with a better prioritization of those who are needing to get vaccinated. What we need to do is identify those who have natural immunity by perhaps giving antibody tests to people who've had flu-like symptoms in the last year. We need to then identify those who are in high circulating positions or have high exposure situations or who are caring for the vulnerable, and ensure that they receive the full dose of the vaccines required, which is 2 doses. And what we would hope to achieve with that is the protection of vulnerable people by surrounding them at least with some barriers, some people who are immune, which will give added protection to variants which are more transmissible. In addition to that, what we want to do is we want to expand our toolbox to potentially consider things that could bolster innate immunity, such as vitamin D, and treat COVID-like symptoms such as ivermectin. So there's 2 videos upcoming on those 2 things. So in summary, we need to leverage existing immunity, and we need to expand our toolbox if we're going to be able to work through our current climate with the least amount of damage possible. So moving along to our summary, what do we need to know about the Ontario vaccination plan? Well, vaccines are safe and effective is what we're told. I do think that we need more transparency around the true toxicity profile and efficacy of vaccines. We need to be more judicious in how we administer vaccines, especially to frail elderly people, because the severe toxicity could very well overwhelm their systems. In terms of vaccinating the elderly, we need to consider that that we might be putting them at undue risk because they're not well studied in terms of population. And again, they might not even confer immunity to this population. And priority should be given to those without natural immunity in high risk of exposure and those who work with the vulnerable individuals in order to protect them. The spacing of the doses by 4 months. There's no efficacy data regarding this, so there's confusion regarding effectiveness and efficacy, and we should guide our practice based on randomized controlled trials rather than real-world studies. And finally, is vaccination the best way to protect against variants? Well, if you're not vaccinated, you're not going to have any protection against variants, so it's important for us to be able to identify people with natural immunity and prioritize the vaccination of those without, in order to create a protective barrier as fast as possible around our vulnerable populations. And we need to start to invest in and expand our toolbox to include options that bolster innate immunity and treat COVID in addition to trying to prevent the disease. So this is the Ontario Vaccination Plan. Help us improve our strategy here in Ontario by sharing, liking, and subscribing to this YouTube channel. Thanks for listening.